and welcome to the third session of breast education under the auspice of Learning General Surgery. And today, to carry forward this program, we have Dr.Selvi Radhakrishna, a renowned oncoplastic breast surgeon from Chennai. Dr. Selvi, please.
Yeah. So I just share the screen in a minute. One second. In slideshow?
Yeah. It's not slideshow as yet. It's still the one before the slideshow.
Full screen now?
Not yet.
Not yet?
Yeah. Yes, fine.
So we did look at some basics of breast imaging last week. We looked at how to assess the adequacy of a mammogram, positioning particularly. And we also talked a little about breast density and quadrant localization. So I thought I will go over the same with some cases which we managed in our practice. So within this, I've put up a lot of images here. So within this, it gives us an opportunity to revise our understanding of mammograms, and I've put up some correlating ultrasound images as well. So I've asked also Kirti to join today. She will join in a bit. So to start with.
No, she has joined already.
Yeah, you there?
No, I'm here, yeah.
Yeah. So this is a 47-year-old lady with a breast lump of 1 year duration, no known family history of breast cancer, and no previous history of surgery. Moving forward. So this is her mammogram. So if, going by what we learned here, how do we check the adequacy of mammogram to see if all the zones are included? This is the pre-mammary zone, the glandular area, and the retromammary zone. And from the nipple, you draw a line backwards. That's the posterior nipple line. And on the MLO as well, from the nipple, you draw a line to meet up the edge of the pec muscle here. So this should be at right angles. And the length of this line and this line should be with 1 centimeter of each other. Then you know both the views are taken well. And also the standard labeling we saw last time, the labeling of whether it's right craniocaudal or left craniocaudal, right MLO, left MLO is always towards the axillary end. So by that, you see that this is a heterogeneously dense breast. And if you look at this, there is a lesion that you see. She came with a palpable lump on the right side. There is a lesion that you see. So going by that, the marking is here towards the axillary end. So this is the inner quadrant. And if you draw this is the upper quadrant. And here, this is the right lower quadrant mass that we see. And it's an irregular equal density mass in the right breast. The left breast seems fine. There are no significant axillary nodes that you see in the right side on the MLO view. And a corresponding ultrasound scan shows a mixed echogenic lesion. So this is a cystic area within which there is a thickening of the cyst wall, if you see here, and within which from one area there is a solid growth protruding into this cystic space. which is irregular, and you see some spiculated edges as well. And you put a color Doppler, you can see that it is very vascular. So there is a very vascular lesions within the cystic mass. So this is how we would describe it. We would describe it as a complex cystic lesion with septation and intercystic echogenic lesion showing vascularity. So we do an elastography. This is a shear wave elastography, and that shows some moderately hard areas, which means it's not a very benign or elastic benign mass. It's likely to be some suspicion here. So we did a core biopsy, and core biopsy showed a benign papillary lesion. So obviously this core biopsies for papillary lesions are very challenging. It's very difficult to convincingly call it benign or malignant, because these are very friable tissue and it gets fragmented as you biopsy. So when you find a papillary lesion, it's always best to excise with a margin, and this indeed turned out to be an intercystic papilloma. So, Kiti, do you want to discuss the next one?
Yeah, sure, ma'am. Yeah, so case 2. So this is a 73-year-old lady who's come with a right breast lump. And again, there's no family history of breast cancer. So here again, as Madam pointed out previously, you do have 2 views that we take on a mammogram. So you can see here the right craniocaudal, the left craniocaudal, the right MLO, and the left MLO. So I think what's important here is that you see one lesion here on the right side on the MLO view, and you see one more lesion on the left MLO view, which is quite obvious. And that's also seen. Is this a smaller lesion as well, ma'am, here?
Yes. So this lady, she came with only a right lump. She had a palpable right lump. And when we imaged, we found this also. So interestingly, so this is the importance of pulling, getting an adequate CC view. So if you look at it here, it's seen well on the MLO, but on the CC, it's at the very edge of the film. So this is the case for an extended CC, include a little bit more lateral breast tissue, then you can see actually lesion pops out here.
Over there.
And it is an irregular lesion, and you can see those little microspicules here. So what is more important is she comes with one palpable lesion here, and we all focus on this side and miss out on what is happening here.
On the
yeah. So this indeed when we did a spot compression, now obviously these images were taken before we got the Tomo system about 5 or 6 years back. So when there we used to do a lot of additional views in terms of spot compression and all that. With Tomo, that these views become redundant because you'd see these very clearly on Tomo without having to do a spot compression. So here you see an irregular lesion, and very well seen. This is the contralateral breast, where she did not have any symptoms. So this is how the palpable lesion looked on ultrasound. So there's an irregular hypoechoic lesion with some bit of after shadowing, and there is a twig of blood supply that you see within this lesion. And on elastography, it is quite a hard lesion, which means it is suspicious for a malignancy. On the left, again, this is the one that was not clinically evident, and it is non-palpable. You do an ultrasound, again, it shows irregular hypoechoic lesion, angular margin you see here, and then put a Doppler there, it is very vascular, this lesion. And this on elastography, sort of not very convincingly hard, but this one feature, angular margin itself, and with the blood supply like this, one and a mammographic image that looked like that, we have to biopsy this. So we biopsied both, and it was indeed a bilateral infiltrating duct carcinoma, grade 2. Both were ER/PR positive and HER2 negative.
Yeah.
So this lady, she had mobility issues. 2 daughters were in the US, and they obviously didn't want to stay in, she comes from down south from Theni, and so the simplest option for her was to have a mastectomy, although this was conservable for her mobility issues and all the social issues. We decided to go ahead with a bilateral mastectomy with sentinel lymph node biopsy. The right side was a 2.5 centimeter tumor, sentinel nodes negative, ERPR positive, HER2 negative, and Ki67 was 10%. On the left, the non-palpable side, the tumor was 1.3 centimeters. And again, same features, ERPR positive and a low Ki67. So the learning point here is to carefully evaluate the contralateral breast. And if you see, this breast is predominantly fatty. The density of this is a reasonably well done mammogram. And here we've done a little extended CC view to include the lateral aspect of the breast as well. And it is a predominantly fatty breast. So where there is less than 25% of the breast is fibrogranular tissue, most of it is fat. And so it is very easy to pick up lesions in a fatty breast. So this is another case. This is a 63-year-old lady with no family history of breast cancer, no previous history of surgery. And she had a routine mastile checkup, and the mammogram was included in that mastile checkup. And this was the mammogram. Kirti, do you want to describe this?
Sure, ma'am. So again, here you see a right CC, the usual views that you take for a mammogram. And she's also got, I would say, more towards a fatty breast. There's not much of dense tissue that you see here. Yeah. But you can see a small dense lesion in the left breast. So if you look at the left CC view, this corresponds to the inner part of the breast. And when we go to the MLO view, you can see here, it's nicely sitting there in the lower outer quadrant. Yeah. So I'm assuming this was also before stomomammogram, because you can see a nice spot view here. So I think one other thing spot view helps with, if there's any extension from the lesion surrounding calcifications that you can't really see on the regular view, you'll be able to pick it up on the spot view or the magnification views.
Yes.
So apart from that, I don't think she has any other significant findings on the mammogram.
Yeah.
Yeah.
And no significant nodes on the mammogram.
Yeah.
Yeah. So again, this is a predominantly fatty breast. And if you look at the ultrasound image here, it's a slightly taller lesion, hypoechoic lesion, and you do see some angular margins here in this one end, and some indentations here, and there's you see a twig of blood vessel here as well. So you see a kind of echogenic halo around this lesion. This is very pathognomonic of a malignant lesion. And so this also was biopsied. So this there is a misconception that smaller lesions cannot be biopsied. That is not true. If you can see a lesion on ultrasound, it almost always can be biopsied. So in small lesions, in order to confirm that your needle has actually passed through the lesion, you would actually take a cross-sectional view as well, just to make sure that you see the needle tip within the lesion. So this was biopsied, and this is a grade 2 infiltrating duct carcinoma. This again, it was picked up on a routine screening mammogram. So she had, this was again non-palpable. And we know from the mammogram, this was in the lower inner quadrant. So this is like Kirti mentioned earlier, the marking is here. So this is away from the marking. So this is the inner quadrant. And this, if you draw a line here from the nipple, it's well below that line. So it is the lower inner quadrant. So it still needs to be localized for surgery, because you can't remove all of the local lower inner quadrant. So what we did is put a wire. This wire was done with ultrasound guidance, and using the wire guidance, this lesion was taken out. She had a wide local excision and sentinel lymph node biopsy. So So she had a grade 2 infiltrating duct carcinoma. It was in fact actually 1.8 centimeter tumor. Node was negative, PR positive, HER2 negative. She had radiotherapy to breast, and she was put on letrozole. So one more case scenario. This is a 48-year-old lady, left breast lump, 4 months duration. She premenopausal, obviously not attained menopause yet. No family history of breast cancer. So, Keith, did you want to look at this mammogram?
Yeah, so I think to start off with, I think this is a dense mammogram because you can see there's a lot of glandular tissue heterogeneity seen on both sides.
Yeah.
On the right side, so if we look at the right side first, again, as you mentioned, if you look at the marking is closer to the outer aspect. And in the outer aspect, there's a lot of calcifications that you can see in this outer quadrant of the breast. Also on the left, so as ma'am mentioned, you should not forget findings seen on the contralateral mammogram. Is that?
This was the palpable lesion. There is a BB on the, so whenever a woman comes to us with the palpable thickening or a mass, we put a radio opaque marker, that little BB. It's a lead ball. It's strapped to the skin with a tape, a micropore tape. And that actually helps you to correlate with the finding with the palpable mass. Yeah. So what the lady feels and you feel corresponds to what you see on the mammogram. So that usually helps to put a BB there. So this white dot that you see here is a BB and not a calcification.
Yeah.
Yeah, so that is MLO.
So here on the MLO, again, same, you can see the calcifications quite extensively in the right breast.
Yeah.
And it's almost occupying most of the upper half of the breast. So predominantly this would be in the upper outer quadrant and a little towards the upper central, if you look at where it's being placed in the mammogram. And coming to the left side, so this is the lesion that we had seen where you can see the BB mark, you can see the solid lesion there, but you can also see a bit of extension coming lower down towards the anterior part of the breast with another small lesion over there as well.
Yeah,
and
so this band usually is filled with tumor, and if we miss this and take only this out, we'll end up having a local recurrence. So that's why it's important to look at a mammogram and adequately.
And I think this was not seen very clearly on the CC view as well, the extension of the tumor.
Yeah, yeah.
So that's why both views are important.
Yeah.
And axilla looks fine. There's no significant nodes that we can see in the axilla. But are there any small spots here, or is that?
No, I think no. So there's axillary tail there, accessory breast, but nothing
within that.
Yeah. So it's very important actually when a woman comes for a mammogram, we might end up seeing artifacts there. If they put a lot of talcum powder when they come for a mammogram, particularly under the breast and in the armpits. So we have to instruct them not to use talcum powder when they come for a mammogram. And if they've used some talcum powder, then actually give it a good wash, wipe it off, and then do the mammogram, because you can end up seeing the talcum powder has a lot of calcium. You'd find a very smudged image, and it can be quite confusing. So another thing here that I would want to show is see how the inframammary fold is open. So this is also important to achieve, to have a adequate view of the inframammary region, because sometimes the cancer can be lurking here and we'll end up missing it if this fold is not included. So what is striking here is she came with only this. She came with the palpable lump on the left side. That's why we put the marker here. And this is what is seen on the left side. But incidentally, she wasn't aware of it at all. This was a large area of pleomorphic malignant looking calcifications. I'll show you a mag view. So this would actually, you can actually see a lot of irregular shaped forms filling the entire quadrant of the upper aspect of the breast. So these would be typically called pleomorphic malignant looking calcifications. So this is how the left lesion looked on ultrasound. So there again you see a lot of irregularity, angular. There's an angular margin. Remember, if you see angles, so you see an angle here like this on an ultrasound, it's almost always indicative of a malignancy. These lesions are suspicious and have to be biopsied. So here again you see a lot of vascularity here, some bit of shadowing, but not much of a posterior feature. On shear wave elastography, you see that it is moderately hard. And this is how the axillary lymph node look. So this is the cortex of the lymph node, which is thickened, and it is not uniformly thickened, it's irregularly thickened. So this is an abnormal node, suspicious for a metastasis. So obviously we biopsy this and we biopsy this too. So what would you like to do for this, Kirti? So obviously this breast cannot be conserved because of the extensive DCIS. So she needs a mastectomy for this. For the left breast, one can plan for a conservation. This will be in the lower quadrant. Is it? Yeah, lower inner quadrant. So you could actually technically do a rotation flap or a slightly longer my cap or I cap to fill in that area. But because she has she's going to have a mastectomy here, and then she didn't see a point in preserving this breast, and we're definitely going to do a mastectomy here. So we ended up doing a bilateral mastectomy here again for this lady. So this lady had extensive DCIS, 2 millimeter invasive focus, 2 node negative on sentinel. So whenever there is high grade DCIS, even though
Dr. Selvi, there's a question in the chat box, if you can see what kind of the needle biopsy is done on the right.
So we did a stereotactic biopsy. So although this is like, this occupies the entire quadrant, anywhere you put a needle into the quadrant, you'll end up getting the representative calcification. But when there is no palpable mass that you feel, and there is no corresponding ultrasound abnormality, you see a finding only on the mammogram, then that is a case for stereotactic biopsy. So stereotactic biopsy on the right showed DCIS, left showed infiltrating duct carcinoma grade 2. And so there was a 2 millimeter invasive focus here. So when I was just mentioning that even though it is only DCIS, we would still, particularly in an extensive high-grade DCIS, we would still do a sentinel lymph node biopsy when we do the surgery, because there could be a invasive focus. Do you agree with this, Kirti?
Yes, I agree, ma'am. I think high-grade DCIs especially, but mastectomy is better to do the sentinel.
Because once you remove the breast, then you won't have a
option to do. Yeah.
So it's always best to combine it with the sentinel lymph node biopsy. So on the left, it was a 2.5 centimeter lesion. Her sentinel node was positive for metastasis. So I ended up clearing this. This again was a few years ago. Now I would be a little conservative about that. I would, particularly if I do a breast conservation. If I do a mastectomy, I would still go ahead and clear it, even if it is one out of 3 or 4 positive. So ER/PR positive and HER2 negative. So because she was node positive, she also had chemotherapy, four cycles of TC, and then followed by hormone therapy. She was premenopausal, 48-year-old. So she had tamoxifen. think there is one more to discuss. So this again, this lady was 40 when she came to us. This again is about 5 or 6 years old. This she had her routine screening, and they found finding. She actually came from Dubai, and her aunt had a breast cancer when she was 60 years old. And this is her mammogram. Do you want to look at this, Kirti?
Yeah, so again, looking at the left, we're looking at the left MLO and the left CC view alone. I would say she's got more of a mixed density breast. You can see some central density seen in the CC view, and then peripherally it's more fatty than dense.
So heterogeneously dense, would you agree?
Yes, heterogeneously dense, yeah.
Yeah.
And on both views, you can see a small area of calcification. So looking at the MLO view first, if you draw that line across from the nipple, this is seen in the lower quadrant. And if you see on the CC view, the fact that it's sitting just at the central area, it's probably around 6 o'clock.
Yes.
Lower central quadrant of the left breast is where we would expect this calcification to be sitting. We can't really see any solid lesions. At least I don't see any solid lesions now.
Yeah.
Yeah.
So it is heterogeneously dense breast, and you see microcalcifications in the central quadrant. So on CC, this technically could be 12 or 6 o'clock, just behind the nipple. So how do you decide whether it's 12 or 6? You look at the MLO. So when you see the MLO, draw a line from the nipple to the back of the edge of the pec muscle. And if it's below, it's usually 6 o'clock. And if it's above somewhere here, it's likely to be 9 o'clock position. So if it is here, this is microcalcification is over here. So this is 6 o'clock position. So that's how you correlate your mammographic finding to the clock position. This again is non-palpable. It's a mammographic finding. You don't feel a lump. The lady is not symptomatic. This was picked up on routine master health checkup. So here you see this is a magnification view. So you see a group of calcifications, again pleomorphic calcifications. So this again, she also had an MRI, and so this MRI, so this is an axial view. So whenever you do an MRI for surgical planning, you need 3 views. One is the axial view, this is the sagittal view, and this is the coronal view. So the axial view tells you whether it is the inner quadrant or the outer quadrant. So this is the midline, this is the sternum, this is the left breast, and this is the right breast. So when you see a projection like this, this is with the sternum there, with the breast like this is called the axial view. And obviously you draw a line right at the center here. This is towards the midline. So this is the inner quadrant, and this is the outer quadrant. And then you do a coronal view, you get the cross section of the breast, like a clock position. So here, if this is the nipple in the center, this lesion is say as around 6 to bordering 7 o'clock position, quite close to the nipple areola complex. So on the coronal view. So it is, you can see that will be the 12 o'clock, this will be 9, this will be 3, and it's 6, and it's closer to the 6-7 o'clock position. And then
Dr. Kirti, there's a question in the chat box from Dr. Ramya. Can you just have a look at that?
Yeah, so the question is, it says, is there a radiodense lesion with spiculated margins just adjacent to this calcification on MLO? Can we go back to the mammogram?
I'll go back on the mammogram.
So while we're taking this question, I just wanted to ask, ma'am, how do you decide whether to do a spot view or a mag view when you have an area of calcifications?
So for calcifications, if you want to see if there is a mass associated with the calcification, then you do a spot compression. However, if you want to look at the morphology of the calcification, whether it's smooth, pleomorphic, or rounded, whether there is any lucent center within, and how is it distributed in that group. So if you want to have and the extent of it. So if you want that, then you do a magnification view. So that's how it's done. And magnification is always done on a 2D image. So even if you spot calcifications on tomo, you go back and then do a standard 2D, because I have started using HD tomo. So then I get a synthesized 2D images. I routinely, I do not do a routine 2D image. I only do a tomo and then use a synthesized 2D image. So, but when I
actually, Selvi, there's a question from the audience, and I requested, the question by the emails by name. I don't know the full name. Sorry. Can you come and put up your point, ma'am?
Yeah, well, I've been doing this for over 30 years. I'm a breast imager in Texas. And, normally, I mean, of course, now everybody does tomosynthesis, so it would have brought out the point. But I do believe that there is a density associated with those malignant calcifications. Would probably show up on a tomo, but as spot compression magnification, we would also have shown it. So we tend to, at least in my practice, we tend to do ultrasound guided biopsies. And so if there is a soft tissue density associated with it, we would just do a true cut biopsy. And that would have solved the problem. But also, like you said, like you showed on the MR, there is definitely a mass type of enhancement associated with those calcifications. So I agree with one of the questions. One of the doctors did bring up the point that there is associated soft tissue density associated, next to the calcifications.
So this, we did not, the ultrasound did not show any mass lesion there. So this was the area of calcification. And
so
there was no.
Did you do an ultrasound?
So yes, obviously all before surgery, all of them get ultrasound. So this was ultrasounded. There was no ultrasound finding, which is why we went ahead and did a stereotactic biopsy. And so this was a stereotactic core, and you could see the specimen X-ray showing some microcalcifications. So we did the MR for surgical planning. Basically, this was again as heterogeneously dense breast, and we didn't want to miss any extent to plan surgery for the extent of lesion. And this is the like I was saying, this basically meant for surgical people to understand how to look at all these images. So I was just explaining the axial view, coronal, and so for our surgical planning to localize and to look at the extent, the posterior, anterior extent, the clock position to plan your incisions, and then to see the axial view to look at the again extend from towards the nipple and behind towards the chest wall. So this is what we did. And this lady, we actually put a wire in and excised the specimen. This was a wire-guided wide local excision. There was no associated mass. Like you see, even in the specimen X-ray, you don't see a mass there, only an area of calcification. So the wire unfortunately slipped out, and it's not seen on the image here, but this is the specimen X-ray. So this was indeed a DCIS, intermediate grade, spanning about 3.5 centimeters. She also had a sentinel lymph node biopsy, which was negative. So you see the usefulness of specimen mammogram is again, you can see that all of the calcifications are removed and the margins are clear. So if you see that, then you may actually avoid doing a frozen section for margins. If you have the facility, you have the comfort of getting a frozen section done, then it is ideal. And then she was also ER and PR positive. So for patients with only DCIS, we don't usually estimate HER2, because HER2 is invariably positive. The relevance of HER2 positivity in situ carcinoma is been studied, but I don't think anti-HER2 treatment is planned in patients with DCIS, and therefore it is not done. And so she had a very C-cup breast, very ptotic, grade 3 ptosis. If you see the nipple areola is stretched and wide, and there was a considerable degree of ptosis. So, and this, the tumor being in the 6 o'clock position, she was an ideal candidate for a vertical reduction. So she had a vertical reduction, and with that technique, I removed the 6 o'clock position, the area of calcifications in this area, which was wire guided. And then that was a specimen X-ray I showed earlier. And this is the result. And she gets a breast lift and as well as a good conservation. So this is a technique that we use for vertical, called vertical mammoplasty, mastectomy. Kirti, any comments?
No, ma'am, I think I would probably plan a similar surgery as well for her. She's got a nice ptotic breast, a lot of extra skin, dense breast. Dense breast is always good to do mammoplasty. It's not as challenging as doing them on a fatty breast. I think post-op complications are also far lesser.
Yeah.
In terms of fat necrosis. So,
yeah.
Sentinel lymph node biopsy, do we routinely do them for pure DCIS on wide local zone?
So sorry, sentinel lymph node biopsy?
Could we routinely do them on DCIS wide local excision? So mastectomy we always do, but on a wide local excision specimen would be
high grade and intermediate grade. I still tend to do Kirti.
Yeah, particularly I think more because people here don't like going back for a second
surgery. So if she did have a focus of invasion, then I have to go and repeat a second surgery for sentinel lymph node biopsy. So which is why if there is a high and intermediate, low grade, I don't bother. Similarly with papillary lesions, with solid papillary lesions, I always combine a sentinel lymph node biopsy. But if it is an intraduct carcinoma, intraduct papillary carcinoma, then I might actually skip a sentinel lymph node biopsy.
Any comments, questions from the audience? Please unmute and ask.
So, Dr. Imes, is it? So, did I get your name right?
My name is, my Indian name is Vimla.
Okay.
But yeah, my name is Elizabeth Vimla Macedo. So I did train in Trivandrum once upon a time, way before you guys were born, basically. And moved to Canada, and then I'm now in Texas. I've been practicing for over 30 years.
Yeah.
So my passion was breast imaging. Yeah. And so, I mean, I started a breast center, ran it for several years, and now I'm kind of semi-retired, and I work 2 days a week.
Right.
And yeah, so I've done tons of everything, you know, including MRs and MR biopsies and all that stuff.
Yeah.
So I was just thinking, you know, those invasive carcinomas that you showed.
Yeah.
The way they handle it over here is they start with chemo, neoadjuvant chemotherapy, and then do follow-up studies. And then once it is all melted away, that's when they do the surgery.
So,
how do you guys handle that?
Yeah, so it's an operable invasive carcinoma, we tend to operate up front. If it's a node positive, ER negative, or HER2 positive, triple negative, these are the tumors that go for NAC, neoadjuvant chemotherapy here. So I must say these images are about 5-6 years old now.
Yeah.
And even now, I wouldn't change strategy. Any tumor that is less than 2 centimeters or early operable breast cancer, node negative, will go for an upfront surgery. But if
even
there is a
hormone positive,
and do you radiate them as well?
Sorry?
Do they undergo radiation as well?
So again, if they are if they have breast conservation, yes, they do have radiotherapy. If they are node positive, then even if they've had a mastectomy, then we would radiate as well.
Okay.
Yeah, Kirti, you're saying something.
Sorry.
I was just saying that most of these cases are also hormone positive, no ma'am. So I think hormone positive breast cancers, we're a bit more conservative with NAST. You tend to do more of upfront surgery rather than chemo unless they are node positive or locally advanced cancers within the
Yeah, I agree, Kitty.
I have a question to you actually, ma'am. In the US with private practice, do they do sentinel lymph node biopsies with high-grade DCIS? Do you have any idea? I know you said you do more radiology, but yeah.
Yeah, they try to see if there is even a tiny microscopic focus of invasion, then they apparently do a sentinel node biopsy. Have you heard of Dr. Tabar?
Yeah, I've learned most of my mammography from Tabar.
Yeah,
so what happened? I'm a surgeon, and I trained early on in Chennai at Adyar and a bit here and there in India. And then I went to UK to do a bit more on breast, because we were only doing Patty's mastectomy, modified radical mastectomy. This was around 1999, 2000. So then I went back for a couple of years to UK, and that was when oncoplastic surgery was an emergent field. Sentinel lymph node biopsies were being validated across the NHS in the UK. So a few surgeons, there was a very strict criteria about how the Royal College of Surgeons in the UK had a validation program, training program for. So all that was happening around, this was early 2000. And so I picked up those skills there. And then when I came back here in 2007, I realized, there was a lot of resistance for sentinel lymph node biopsy, and very, very difficult to get. There were some centers doing good mammograms, but on the whole, it was very difficult to get good images. And it was obviously not there was no common platform in understanding radiology, guided interventions and all that. So then in 2009, I invested and got a machine, a digital machine. So that was the first actually in this part of the country. I got a Hologic digital machine, 2D machine. And then I also did a few TABAR courses. I did three times actually. I kept going back again and again, 3 times to TABAR's courses. Then I went, did a couple of ultrasound courses. I did one with Stavros in Dallas, and I did one in Italy. And I did a screening program in LRCB in Netherlands. So where there are didactic lectures, and they run through 1,000 mammograms, and all of them were analog at that point. It was not digital. Digital was just like they had enough images to look at. And then they validate you. So they make you you go through a test, and you read 100 mammograms, and they score you, and then say you're all right to go and read screening mammograms. So that's how I picked up mammogram. And then I also did Mike Porter's course on MRI in Seattle.
You mean Bruce Porter? Bruce Porter.
Bruce Porter. Okay.
Seattle?
Yeah, Seattle. Yeah. So this is just after he retired. I think he had one last course at that time. So I went there and did that course. So that helped me plan my surgery better. And now I enjoy talking about imaging. And
let me give you a pointer. If you love Tabar, because he's still very active, he has every Saturday morning for me would be evening for you, for free. He has some amazing lectures for about 3 hours.
Right.
And
I didn't know that.
It's really worth tuning in. And if you give me your email, I can send you the link for the MEI lectures.
Oh, great. Yeah.
Yeah,
that'll be great.
Amazing. He's a friend of mine. Actually, I helped him do the prostate breasts. He compared, prostate and breast, and he put out a book about that. And so anyway, if you look, like, he would argue about this particular case. I'll tell you that, because I just watched him on Saturday morning, and he had these cases of DCIS. He hates the word DCIS. He calls it in situ. But even so, he doesn't think that they are, because he says there's neoduct genesis. And
Yeah.
therefore, that question about sentinel node biopsy, he would definitely say yes, even if it is supposed to be just in situ, because the neoduct genesis is actually an invasive cancer.
Yes.
And also the proximity to the nipple, because if these calcifications were further back, he would say, fine, do a lumpectomy. But if it is close enough to the nipple, even though there is no, you don't really see it even on MRI, what I do usually for MRs is I lower the threshold for the CAD overlay. I don't know if you use CAD color.
Yes, we don't have double reading on mammograms, so we do use CAD.
CAD for the MRI.
Most of our work is diagnostic mammogram. So
I'm talking about the MRI, because that'll show the invasion of the nipple. I mean, that it goes towards the nipple. So he would say you cannot conserve the breast. But anyway, it's I don't want to take up your time, but it is just one of those things. I can send you the email if you're interested and share with your colleagues. But he's amazingly educational still. All his lectures.
That's Vimla, if you can type because so many of them are interested now. If you can type the email ID, your email ID here,
okay,
in the chat box, that'd be, because there's so many who put up their email IDs there, so they can copy your email ID. If you can just type it out. I will be glad if you join us every.
Actually, I trained in Trivandrum Medical College.
Yeah. Wonderful.
We'll be glad.
We're glad if you can join us every Monday between 8 and 9:30.
I will try to join, because I only work Tuesdays and Fridays. I'm retired.
Well, it'll be good to have you here for our.
Well, thank you. I would love that, because it's a passion of mine. Yeah. And since I follow, unfortunately, we don't do MRIs, but I'm telling you, I do most of my biopsies using ultrasound, because those calcifications I would have seen on ultrasound. You could have done it on the ultrasound, the way we do it. But anyway, you have to do it the way you do it. I'm just saying, I mean, we can't compare. We have to compare the ways we do stuff. But I really wanted to come back home to India, move back, and do some voluntary work. But I'm from Kerala, so I wanted to actually do some work over there. I still might.
Yeah.
I have one query, Dr. Vimla. So you were saying that you wouldn't advise a wide local on this if you see a calcium. If you get, I don't know, how widely do they do frozen section in the US? Because if you get a clear margin.
They don't do frozen sections at all.
They don't. Okay. But if we get a good margin on frozen section, then why not conserve the nipple? Is there?
But he says, this is Tabar's thinking, not, and actually, I mean, my personal experience, I have actually told the breast surgeons, please do not conserve the nipple because it's close enough. And then 2 or 3 years later, guess what? The DCIS has come back and it's involved the nipple. And not only that, sometimes these patients won't come back for their follow-up. They come back with lymph node metastases because it's so close to the sappy plexus. I mean, it's going to be moving. And if you take, and I truly believe Tabar's theory, which nobody else has, none of the pathologists believe, but it is a drilling type of cancer. So that is why you can get DCIS type calcifications in lymph nodes. I have personally seen that. How can it be just in situ cancer and get to the lymph nodes? So his theory that this neoduct genesis is actually an invasive cancer. So he doesn't believe there is such a thing called in situ cancer that is not invasive. Whether it is grade 1, 2, 3. And his theory about grade 3, I mean, we all know that grade 3 is a stem cell origin. It's totally different from grade 1 and 2. But they can all do the neoduct genesis business. So, and my experience, I've seen so many cancers return, the so-called in situs, in spite of radiation.
Okay, I was just going to ask. So they all standardly receive radiotherapy, or are they cutting down on radiotherapy in low-grade DCIS, small areas?
Okay, that's up to the. It is like
up to
the surgeon and up to that particular scenario. But to tell you the truth, I worked mostly in Oklahoma. I just moved to Texas maybe last year, the beginning of last year. I think Texas is backwards compared to what we were doing in Oklahoma. It is amazingly redneck backwards. Unless I worked in a big center. I was asked to work in the Methodist Hospital in Dallas because I've got so much experience, but I did not want to work so much. You know, I had to work 5 days a week. And I'm like, no, I'm going to do 2 days. And I'm not kidding you, in this place, Granbury, which is a small town, relatively small town, I picked up 9 cancers on a screening mammogram in 2 weeks. So it's really pretty backwards. USA is not that advanced. So I think Europe and England and all those places are actually more advanced than this country. They don't want to hear that. But anyway, I'll be happy to share my experiences, but I will also send you the link for Dr. Tabar's.
Yeah,
because if you listen to him, you will truly believe him, what he's doing. You know, he's a pathologist as well, not just a radiologist.
So he actually compares this CIN of cervical cancer to DIN, ductal intraepithelial neoplasia.
Yes.
And so this
even carotids. Yeah. He was talking about carotids 2 days ago. Why do they consider the, you know, adenocarcinoma of the carotid so bad, and then they don't consider this so bad? I don't know. He's all over the place, but he's brilliant, you know. So I think it will help if everybody watches him as well.
Yes.
I'll be happy to share the link. I can put it on the website, on the Facebook if you want.
That'd be wonderful. Can you type your email ID, ma'am, here, Dr. Vimla?
I did put it in chat.
Oh, did you?
Did you get it? Yeah, I did type
it. Yeah, it's right on top. It's there.
Oh, right.
Yeah.
Thank you. So I didn't see this.
Thank you.
Any more comments or any before
really
we? But it's nice you joined in, Dr. Vimla, and extremely nice, Dr. Kirti. I think you should be ready for the coming weeks. We do this session every Monday.
I'll be happy to join and learn from you guys as well, because you know I want to move back home, and I want to know how things are done there. I can't just go with my experience over here and go over there. It'll be very disappointing. So actually, I did speak. I was a speaker at in the Society of Breast Imagers of India. When it was in the National Institute in Bangalore. Yeah. Yes. 2016.
Yeah, a few years back. Yes.
Yeah, and I also brought some of my, I travel with a flash drive of all my cases. So I presented it in St. John's Medical College in Bangalore and also in Trivandrum. I'm not in the academic field at all, but I used to make, you know, all these slides and stuff. So I'll be happy. Thank you so much for allowing me to join.
Thank you. And we look forward to your presence for every meeting.
I will.
Yeah.
Even if I have to get up early morning, it's early morning for me. But it's, you know, even if it is 8:30, it's morning for me. But thank you so much.
Thank you.
Thanks everyone for a wonderful session, ma'am. You added glamour to the whole evening, and of course that Kirti had come in, and we'll see you again next Monday at 8 o'clock. Thanks once again.